everyone, I'm Kisha, your host of Beauty and the Wise, the ultimate lifestyle and wellness podcast where we empower and encourage women over 40 to redefine the narrative around what getting older looks like for them. Aging well, empowered aging, healthy aging. Some even call it anti-aging. We are here to help you with providing tools and tips and knowledge from topics ranging from hormonal health to sexual wellness to personal development, mental and emotional health. Nothing is off the table. We want to be able to empower you to advocate for your own health and well-being. Today, we're going to continue talking about this hormonal journey. As I've shared with you, I am in menopause, and I only realized that I was going through the perimenopausal symptoms once I got into menopause. So I was going through this for years, not having a clue how to address these symptoms. And now that I'm in menopause, I have been hearing the words HRT, which hormonal replacement therapy or treatment, some people like to talk about. Today's guest is a good friend of mine that will help us break it down because, with any topic, there are benefits and, disadvantages, pros and cons. There's so much information out there, these myths. There's things that tell you what you should and shouldn't be doing. So we want to clear the air. We want to hear from an expert that's going to help us navigate this journey that we just continue to be on. And again, whether it's puberty to pregnancy to perimenopause, menopause, or even postmenopause, our hormones are always changing and we're going to need the help. Dr. Annabel Fountain of Fountain Health, welcome to Beauty and the Wise.
Thanks so much for having me. And what a privilege. Thanks for asking me.
No problem. Now I know you, my Bermudian friend. We go way back playing tennis as well.
That's
but please,
right.
For the audience, help us understand who you are. How did we get here? Tell us about your journey.
Okay, so the first thing that's quite funny is that people don't realize I'm Bermudian because I went to school in England and they told me to stop talking like an American, right? And I used to have a proper Bermudian accent like you, right? So anyway, that's gone. I came home in 2010. I trained in London in my specialty. So I'm qualified in endocrinology, diabetes and metabolism, and internal medicine. So that's my specialty areas. So I have a really, really interesting job because every day is different. Every individual person is different and their experience of their life is different. So whether it's diabetes or thyroid problems or going through menopause or trying to get pregnant, those kinds of things, it's from the beginning to the end. It's really a very, very interesting career. And myself, I went into menopause early. I did IVF when I was in my late 30s, probably 38, 39, losing track now. And I wasn't told that I was going to go into early menopause, even though I had very low anti-Müllerian hormone, which is how many eggs you have left. Mm-hmm. And I'm an endocrinologist and I didn't know. So that just tells you how badly this is taught, how little people talk about it. And so when I realized that this was what had been happening to me and that I was going to be in menopause, so that's since 2019, I've been on HRT. I was just like, well, I better be very good at this, yes. Right? Because it's me. And it's also most of my friends, right? Mm-hmm. Because I'm going to be 50 next year. So most of my friends are either going through it or have gone through it at this point. And I get a referral every day. Wow. for perimenopause and menopause management. So it's really very close to my heart. And I really appreciate the opportunity to talk more about it.
Okay, so let's jump in. Help us understand HRT, breaking it down, hormone replacement therapy.
That's right. So actually HRT, if we really think about it, most of endocrinology is affected by HRT. If you have type 1 diabetes, your pancreas doesn't make insulin, I give you insulin. Insulin is a hormone. Your thyroid doesn't work, I give you thyroxine. If you have adrenal failure, I give you hydrocortisone, right? So when your ovaries fail, I don't want you to think about HRT as being anything other than hormone replacement. It's not a medicine, right? It's something you're missing and we're replacing it. Now, the hormones that we give now are very, very different from 20 or even 50 years ago. A long time ago, they used to get horse urine and get the estrogen out of that, and that's what they gave women. The progesterone portion often is synthetic, and it still can be synthetic now, like we get in our oral contraceptives.
Okay.
Right? So the hormones that we have in oral contraceptives are pretty similar to what we get in our hormone replacement therapy now. Okay. So there's two portions, estrogen and progesterone. Okay. Everybody knows what those are. When you're going through puberty, that's when you start feeling the changes in the way that hormones make you feel.
Yes.
So increased anxiety, mood swings, poor sleep, sweating, weight gain, hunger, anxiety, depression, nausea. Like there's so many symptoms. And when you realize what all these symptoms could be, usually after the fact, right?
Yes, of course.
And if you are lucky and you have a physician who's attuned to this, they might say, oh, I wonder if you're in perimenopause. But you know that these hormones that change different every single day of the cycle, and that's predictable if you have a predictable cycle, right? So perimenopause is like the opposite of puberty, right? As things are kind of, I guess, unraveling and changing in the other direction. And so people start having really heavy periods. Their skin's breaking out and it hasn't for ages. They can't sleep anymore. Their hair falls out. I mean, it just goes on and on and on. And so there's a lot of things to do to assess. It's not just blood tests because, as I said, every single day is different. So if you do blood tests on this day, your estrogen could be really low, and then I do it next week and your estrogen could be really high. And if you go to your doctor with week 2 lab results, they're like, oh, well, you're not in menopause, right? But if you've done the blood tests the week before, they show a completely different picture. And so you really have to listen to the symptoms and realize, at what time of life somebody might be in. Because perimenopause can start really up to 10 years before your final menstrual period, right? The average of which is age 51. And so it could be going on for 10 years before that. It's only called early menopause if it's before age 45. So I win that prize. I went into early. So, yeah. So I was 44. And if it's before 40, then that's really called premature menopause. So that would be somebody who's, that there are reasons why that can happen. But the symptoms would be the same. And then the treatments would be the same.
Okay.
Yeah.
That's interesting. So for me, again, I definitely been the before 45. I was in my 41-ish when things just stopped. Like everything just changed for me.
Right.
And like you said, the symptoms were there. No one could tell me that, oh, you're too young. You're too young for menopause.
Too young.
It's stress. You need to manage your stress better. I had no idea that I even needed any sort of hormone replacement at the time.
Yeah.
So someone that's going through this, what do they need to understand? Because there's so many myths out there. Let's just break it down. Let's just go through these various things, because you could open up Dr. Google and HRT causes cancer or HRT premature death. Help us understand this.
Okay, so anybody who says that HRT causes cancer is 20 years out of date. All right, so that's the first thing.
Got it.
So the Women's Health Initiative study, which was, thousands and thousands and thousands of women, mostly nurses, so not exactly unstressed people. But anyway, the Women's Health Initiative was studying women with and without HRT. The estrogens given were conjugated estrogens. They were often oral, which we don't usually give oral estrogens anymore. The progesterones were progestins, not progesterone, not what we now call bioidentical. Okay. And of all these women, you probably had people from 45 to 65, and they're all in the same pot, right? So you're comparing apples and oranges, right? So if I went through menopause and at this point you're starting to get the adverse effects of low estrogen, so weight gain, higher blood pressure, less favorable cholesterol profiles, so many different things that are indicating that your health is not as good as it was before. And you start someone who's 10 years post-menopause on hormones, that's really not the same as starting somebody who's just in perimenopause on hormones and continuing them through.
Okay.
So what those studies showed was that if you started someone on hormone replacement therapy more than 10 years after menopause, it increased your risk of heart attack and things like that.
Okay.
But we don't want to do that. We want people to be on HRT from pre-menopause, right? And also the hormones were different. So we can't say that they're unsafe. We're not using them anymore, right? We're using them in younger people. We're helping them to stay healthy. So we're not dealing with the weight gain, the blood pressure, the high cholesterol, right? And we're using bioidentical hormones. We're using transdermal estrogen because that, if you use oral estrogen, it increases your risk of blood clots.
Okay.
Right? And the other really exciting data is that with the breast cancer risk, really doesn't increase your risk of breast cancer. Estrogen on its own can potentially reduce your risk of breast cancer, right?
Okay.
But if you have the gene for breast cancer, you're going to get breast cancer.
Exactly.
Right?
Exactly.
So we are all very, very careful to have our mammograms, do our self-checks, those sorts of things so that we find breast cancer early, right? The risk of having 2 glasses of wine per day increases your risk of breast cancer more than the risk increased by HRT. So it's really, really low risk HRT. So we don't want to worry about it. Taking estrogen on its own, you can do that if you don't have a uterus. So somebody who has had a hysterectomy for whatever reason, they can take estrogen on its own. If you have a uterus, estrogen's job is to prepare the lining of the uterus for implantation for having a pregnancy, right? And that's why when you have your period, it sheds because you didn't get pregnant, right? And when you are on the pill and you stop the pill, you bleed because the estrogen level dropped.
Correct.
Right? So if I give you estrogen and you're getting it continuously and you're not bleeding, it's just going to cause that build up. And so that can increase your risk of endometrial cancer, right? So that's cancer of the uterus, which we don't want to happen.
But this is just if you're taking it on its own.
On its own.
Exactly.
Right? If you have a uterus, right?
Exactly.
It can't happen if you don't have it, right? So what we do is we give progesterone as well, because progesterone balances the estrogen and it stops that proliferation of the endometrial lining. Now, I have a lot of people who are just on progesterone because if you think about that estrogen is causing that proliferation, that can be part of why your periods get really, really heavy in perimenopause. So some people that doesn't happen to, but I have a lot of people where they are just flooding, hemorrhaging, really, really dreadful, no white trousers ever. So like really, really difficult to manage. And so they still have plenty of estrogen most of the time, but their progesterone portion is failing first. And so we put them on progesterone. Women who have low progesterone are usually also complaining of poor sleep.
Okay, so this was me. I started on progesterone. I wasn't sleeping. I was moody. I was irritable.
Yeah.
So that's where I started.
Yeah. And so if you're not having hot flashes, people are like, oh, you're not in menopause, because that's what everybody talks about. They talk about hot flashes and sweats and night sweats. But if your estrogen is still pretty good, that's not happening, but you can't sleep because estrogen is energizing and progesterone is calming. So if we give you the progesterone, that can actually take you through quite a few months or even years before your estrogen starts dropping, at which point, yes, a lot of people get hot flashes, but not everybody. And their hair, that's usually the estrogen, or iron deficiency because of heavy bleeding,
Yeah.
right? So there's lots of reasons why people have the hair loss as well. So I have a detective job to kind of go into every little rabbit hole and figure out what is causing what. But if we're not really sure, I'll quite often get people to start the progesterone first, because then they know that's what progesterone feels like.
Yes,
you know?
exactly.
And
I
it's
definitely
amazing.
have my best night's sleep as soon as I take that.
Yes. Yeah, absolutely.
I
So,
notice a difference.
yeah. Do you not take it every day?
I do. I take it
Okay,
every
good,
day now,
good.
but
Yeah.
initially
Yeah.
that was all I was on.
Right.
And I went from sleepless nights to, oh my God, I feel so much better, because
So different.
when you don't have a good night's sleep, the next morning, your day is crap.
Absolutely.
Basically.
Yeah. It changes everything if you can sleep. Yeah. Yeah. So that's why everybody has to be on progesterone if you have a uterus. If you don't have a uterus, then you don't have to have the progesterone. But if you're still not sleeping, then you want to be on the progesterone. The other hormone that we all have or had that can be insufficient after menopause is testosterone. Now, everyone thinks that's men's hormone, but women have it as well. And I certainly wouldn't give you the same dose as I would give a guy, right? Because you get hairy and you get more spots and you would lose more hair. That's why men go bald. But I would give you DHEA,
Okay.
which is actually over the counter. It's a precursor to testosterone and estrogen. And it can increase your testosterone levels. So that can help with libido and energy. Sometimes as you get older, you find it more difficult to build muscle and to feel strong. And so a little bit of DHEA can help. The FDA has not approved testosterone use for women.
Okay.
The Australian Menopause Society has, and they actually produce a product specifically formulated for women, which we could get here, but it would cost you an arm and a leg. So what we do is we actually use the men's formulation, but get one of the pharmacists to dilute it down so that you're getting 10% of the male dose, or even 5%. So I usually start people on 5% so they see how it feels. Remember that all the wars in the world are started by men, right?
Yes.
Right. So testosterone is not always good for your mood.
Exactly.
So we just got to kind of play with it
Find a balance.
Yeah, find a balance. And it might not help. It might not be the answer. Some people just, they feel better with it, able to focus more. A lot of the thing that people talk about now with aging is dementia, right? And apparently twice as many women develop dementia as men. And so there's a theory that it might be related to testosterone. A lot of women complain of brain fog during perimenopause and menopause, like having a conversation and then
Forget
literally
mid-sentence.
mid-sentence. It's almost, when your computer is, it's working, and then it stops.
Yes.
And you have the blue wheel.
Yes.
Right. That is literally how I feel, what my brain does sometimes. It's literally the blue wheel going around. I'm like, come on.
Exactly.
Come on, reboot. Anyway, and then it starts again, which is fine. But yeah, there's a lot of different symptoms. Sometimes estrogen's all that you need. Of course, getting good sleep.
Absolutely.
Yeah. Exercise, really, really good. I need to do better at that. And then, yes, you can add other things like testosterone and vitamins to help with brain fog.
So what are the risks? What are people concerned about? Because I am all about a quality of life and not suffering.
Yeah,
So
absolutely right.
why, I just want to understand, why do people kind of hesitate when you mention the words HRT or the letters HRT?
Because of the Women's Health Initiative.
Okay.
Because women were terrified because they did have an increased risk of breast cancer in certain groups, but it wasn't true of every single person.
Got it.
Right? So even women who have had breast cancer, right, or they've got it in their family, if they're suffering and they can't work anymore, they're not functioning enough to hold their job or look after their family, this happens, right? Then you really the risk to your mental health is really significant. So the Women's Health Initiative did a lot of harm, right? we have re-examined, it's the royal we, have re-examined the data and it's not true, right? So that increased risk of cancer is not true. You can dive down and you can find the people who may have an increased risk. If you, for example, your whole family dies of pulmonary embolism with blood clots, well, if that happens, you should be on anticoagulation anyway. If you have those genes, because you can test for it.
Yeah.
If you have those genes, then you should be on blood thinners for life anyway, in which case you can have HRT.
Okay.
Right? Okay. So, and I'm talking about people I know that I've looked after, that I've discussed with the hematologists, and we've kind of made these sensible decisions that are very, very individualized. It's not everybody gets the same thing.
Exactly.
Right?
Exactly.
It's who are you? What's your history? What's your family history? What are your individual risks? And almost all the time, it's okay.
Okay.
Right? You can still use hormone replacement therapy and you can adjust it to what feels good for you.
Okay. So what would you say to women when it comes to when should they start? Like, is there a certain point? Is it too late? Is it too early? What happens?
Okay, so the too late piece, we are still sticking with what the Women's Health Initiative said, which was probably not going to start it more than 10 years after menopause. Okay. Having said that, if you are super fit, you've got amazing cholesterol profile, your blood pressure's normal, you're not overweight, all of those things, and you're suffering, okay, you're much lower risk than someone who's had that sort of postmenopausal, middle-aged weight gain, and your cholesterol looks terrible, you've got fatty liver and pre-diabetes. That's a totally different person.
Exactly.
Right? So, again, if somebody's really suffering, we could try it.
Okay.
Right? We're trying to maintain health. So what's happened in our sort of extended living that we have now is that we are dying longer.
Okay.
Right?
Yes.
As opposed to living longer. We are getting older, but we're not living. Like sitting in a nursing home for 10 years with dementia is not living, right? And so if we can think about how can we age healthily, that's what this is all about, right? And HRT apparently reduces your risk of dementia by 73%. Estrogen is a neuroprotective hormone. Okay. So a lot of women come to me and they talk about the brain fog, or they, they're scattered. So they've probably had ADHD their whole life, right? But they've always been able to manage it, and it's just been a superpower. But when their estrogen's dropping, it's just not working anymore. The other thing that quite often comes up is multiple sclerosis. So multiple sclerosis can happen over decades, and you might have had a numb toe in your 20s. The ones that present in their 20s, which is when it usually sort of starts, will present with something quite devastating, like the double vision, or they go blind in one eye and then their vision comes back, or they've got weakness and then it gets better. But if all that sort of happened when you were asleep, it still happened in your brain, but you never really noticed it, or you just had a bad day, or I had a headache and I must have had too much to drink last night, or that kind of thing. So you just brush it aside. Women brush a lot aside.
Yes, we do.
And then at menopause, you start getting symptoms because your estrogen's dropping. So it's really interesting how that develops, and how if you start assessing people and you give them their hormones back, that actually really helps them to manage symptoms of not just hot flashes and sleep, but other sort of neurocognitive issues. And this is probably why, estrogen deficiency is probably why we have more dementia. Testosterone's being investigated for that as well. And of course, we have not been living very healthily the last 50 years as a population, and not just Bermuda, global. The food that we eat isn't the same. We don't move as much. Speaking of which, the reason why exercise really helps with brain function is it increases a hormone in your brain called brain-derived neurotrophic factor, BDNF. I learned this from an MS colleague. And so exercise increases that, and neurotropic means nerve growth, right? So it's actually helping your brain to repair.
Okay.
Right.
Okay.
So everyone says, oh, once a nerve is dead, it's dead. That's not true. We know that's not true now. And so really, the exercise part of it also helps you with sleep. It helps you with your weight. It helps to balance so many things. So if you were going to ask me, because I know you were going to ask me about what other things other than hormones can you do to help with these symptoms, exercise is definitely one of them.
Okay. And what about the emotional and psychological help? Like, how can hormones help in this area?
Okay, so the anxiety, I've had people come to me who have crashed their car because of palpitations, because they thought they were having a heart attack, gone to the emergency room multiple times, passed out because of anxiety, like hyperventilation, because their heart's just going crazy. And so this is totally overwhelming, absolutely shouldn't be living like this. Progesterone calms it all down. Amazing. And a little bit of estrogen. So a really interesting description the other day was, I feel like I've swallowed a mobile phone and it's vibrating, like this vibration feeling inside, like it's just this fluttering anxiety, stage fright kind of feeling, sometimes nausea, right? And that actually giving a little bit of estrogen can calm that down too, like, because it's kind of that adrenaline, right, that's happening. So it's a really stressful time. And especially when you don't know what's happening, you think you're going crazy.
You do. So
right?
trying to assess all these different factors and make a decision. Do I go to the doctor? What am I asking when I go to the doctor? What am I supposed to be? How do I even start this conversation with?
Right. So I think a lot of my referrals now just say, please see this lady. She wants to talk about her hormones, right? So, I mean, it's pretty vague. And I'm like, okay. And I look at the age, I'm like, okay, I know what this is going to be about. But, your primary care provider has 15 minutes if you're lucky,
Exactly.
right? I have an hour for the first appointment. I have 30 minutes for your follow-up. And I listen, and I'm typing. It's kind of going in my ears and in my eyes and into my brain and out my fingers. And I'm like typing to try and make sure I don't miss anything, because it can really, really tie together. And if you miss something, oh, maybe it's not that. But, and I want people to tell me everything. They're like, oh, sorry, it's a lot. I'm like, no, it's a lot. Right. So having time is the biggest thing. It's really interesting with both sexes, right? You'll tell me things 5 minutes before the end, right? I'm like, oh, if you'd said that,
say that 20 minutes ago.
Yeah, but if you're not comfortable as well, you feel rushed, or you feel like someone's not going to understand, then you're not going to be as open, maybe. But yeah, by the end, or you come back and you say, I wish I'd said this to you last time. Actually, this has been happening. So people will say, oh, no, I don't have erectile dysfunction, or no, I don't have vaginal dryness. No, it doesn't hurt to have sex. But next time it's like, you know what? I do.
Does.
Yeah. And just because they're finally feeling more comfortable. Gynecologist, right? Talk to them. You're supposed to see them every year. You're supposed to have that most intimate examination, which is like the worst day of my year. I hate it. So, if you've got problems with sexual function, orgasm, libido, vaginal dryness, painful sex, you've got to talk about it, right? Primary care as well. It's difficult. So some people are really comfortable with their female providers as opposed to their male providers, right? So that's why for women, having those two specialties might be good, that you have your primary and you have your gynecologist, so that maybe one of them you feel like you can say anything to, and if you're looked after by women, apparently you're more likely to live longer. So, that's a fact too.
There's
Women,
study for everything.
there is. You know why? Because women ask for directions.
Absolutely.
Right? Men don't ask for directions. They,
wouldn't know.
you know, I pick up the phone and talk to my colleague and say, you know, what do you think of this? Right? If I don't know, I've got my mates over in the UK or in the US, and I'm like, what do you think of this? This is weird, you know? And you learn every day. You can't ever assume that you know everything.
Exactly. And especially as being a patient coming to see my doctor, I want to ask the questions. I want to know what is going on because people may not connect the fact that you have vaginal dryness with actually you may be going through perimenopause or menopause. Yeah.
Exactly. And people say, this has been happening since after my last child when I was 32.
Exactly.
Right?
Exactly.
I mean, that's amazing. It's amazing. It's been going on for a really, really long time, and people just have not understood what it is. One of the things that I do when I see someone is I actually go through the menstrual cycle with them.
Okay.
Right? So here, this is the peak of your estrogen before your ovulation. That's when you're horny, right? If you don't have enough estrogen, you're not going to have a libido, right? Here's where you'll get your migraine and your premenstrual headache because your estrogen and your progesterone are really low, right? This sort of big changes. Here's where you're going to be more anxious, right? Here's where you're calm, nice high progesterone. So there, and also all the different physiology. People say, oh, I had regular periods, always had regular periods. Oh yeah, I was on the pill, right? Because the pill is given to women who have irregular periods and acne, not just for contraception. So many women, like from girls, right, from young girls, don't even know what normal feels like because they've been on the pill their whole sort of adult life, and then they come off it to have children, and then after that they're trying to, oh, I don't want to be on this anymore. I want to know what's going on with my body. And then it's a bit scary because you don't really know, the periods don't come on time. And that's, if you're in your late 30s, then you're probably going through perimenopause. It's starting, right? A lot of people don't feel good on the pill, but they take it because it's convenient, or they don't know any different.
They know nothing different.
They know nothing different. And they've been on it since they were 15.
Exactly.
Yeah.
Which brings me to, when you think about it, someone being on the pill or on the shot, whatever it was, birth control wise, they know what they went through. They know what they experienced. They came off it. They may feel a little anxious about any sort of HRT sort of therapy or treatments. You know, how do you help them through that? Understanding it's not the same experience. You know, you're at a different point in your life. Yeah.
So the hormones are different. So remember that. So with the shot, they now give a combined hormonal shot. It's got estrogen and progesterone in it. The progesterone only shot causes osteoporosis. You need estrogen for your bones, right? So no periods, great, right? But no estrogen, no hormones. People who have anorexia nervosa and their periods stop get osteoporosis, right? So this progesterone shot actually can be really detrimental to your bones. So now they do a combined, but make sure that's what you're getting, right? So the big difference is that the hormones we're giving as HRT are actually these bioidentical hormones.
Can you break that down first? Bioidentical.
B-I-O, right? Identical, right? So it's bio means body. In the UK, one of the doctors calls it body same or body identical. They call it that just to make it clearer, but it's bioidentical. It's exactly the same as what your body would make when you send someone to the lab and test them for estrogen, estradiol. It cannot tell the difference between your own and what's being given you. It is usually a patch or a cream or a gel or a spray, and we're giving it transdermal. And then the progesterone, the little pills that we take as the progesterone are also bioidentical. Once your body absorbs it, it's the same as the natural progesterone. But you can also give progesterone as creams and gels as well.
Okay.
Some of the patches have progesterone and estrogen in them. The estrogen, estradiol is still bioidentical, but the progestogen usually isn't.
Okay.
Okay. So it's just about what you want, about how you want to do it. but it's not the same as what you had in an oral contraceptive. It's not the same hormones usually.
Okay.
So I wouldn't worry from that perspective.
Okay. I know, just people have memories from...
Absolutely, yeah. Oh, the Mirena made me bloated and felt terrible, etc. People say, oh my goodness, my boobs are really swollen. I feel like I've got PMS all the time. They feel bloated. So then we just adjust the doses of things a little bit, right? So it's a
just that relationship that you need to have to balance it out.
And adjust things, right? Because the other thing is with HRT, if you're taking the same dose of something every single day, that's really nice because you don't have this thing.
Yes.
Right? And so you should be calmer. But it's not the same. You're not going to feel the same. You're not going to have this horny day.
Exactly.
Right?
Exactly.
Right? It's not going to happen because you don't have the fluctuations of your hormones.
And you're right. While you may have given it or prescribed it 6 months ago, you may need to change something. You may need to tweak something.
Yeah, because if you're in perimenopause, that's not the same as being in full menopause, at which point the levels are very low and are not fluctuating at all. Whereas at sort of 10 years and moving up towards it, you've still got huge fluctuations. But when you are going from high estrogen to a crash, right, which can be related to huge fatigue, and I give you estrogen that you take regularly, right? Even if some days you have more than others, you never have that real crash. So that can be helpful too.
Exactly. I said to someone the other day, they were asking me, we're talking about HRT. And I said, to be quite honest, being on it now, I feel like a different person than when I wasn't. When I think about years ago, again, I was angry. I was irritable. I was forgetting everything. I was so moody. I was tired. But no, I feel that balance. I feel that calm all the time.
Yeah.
Because it's balancing out.
You don't get that horrible PMS feeling.
No.
Yeah.
No.
Yeah. No, it does make a huge difference. The calm. Yeah. So after the storm.
Exactly. Okay, so now you get your referrals, but how can people get in contact with you? How can people find you if they didn't have a referral?
Okay, so I have a website which is fountainhealth.bm, and you can actually send an email, contact us through the website. And we like you to have a referral. The reason is that I like to be holding hands with your other doctors. Okay, so if you come to me without a referral, I still want to tell your GP and your gynecologist what we're doing, right? Because they need to know. And so ideally, you've been referred by them and they've sent me lots of lab results and, you've had this scan and that scan and this is your history. And it just saves us some time.
Okay.
We're a step ahead. And it means that I'm already holding hands, like as a team for you, right? So ideally we have a referral, but you don't need to have a referral. It is really helpful if you've had tests done, wherever you've had them done, America, UK, wherever you've had them done, collect them, bring them.
Okay.
I'm interested in 5 years ago or even before. So having previous information is really, really helpful. And then, if you don't have a referral, we just make you an appointment. You bring as much information as you can. And that's that. My office does have a phone number. It's 232-2027. And my staff are very, very nice and they'll help you navigate what to do. And if you want to just look at things that I think and things that I like, I've got Fountain Health has an Instagram, it has Facebook. So, the resources that I use or that I'm reading, I'm kind of posting or reposting as well as doing my own content.
Okay. Sounds
Yeah.
good.
Yeah.
That's good. Now, I like to ask everyone that's a guest, what would you tell your younger self? Being you're all in this health and well-being space, thinking about that, what would you tell your younger self?
Oh, I think exercise is something that's really a challenge for me. I do not like it. I don't like it. And so I think getting into a routine with physical activity, where it's something that is just normal. Like, it's not normal in my family, right? It's not just me. And there are things that I don't mind doing, but prioritizing that is really, really important. And that you're beautiful, right? That is the saddest thing, is me looking at pictures where I thought I was fat and ugly, and I'm not, right? I'm beautiful. And, you know, just really, really realizing that that everything about you is beautiful, right? Nobody's perfect. But enjoy life. Yeah, that's what I would say to my younger self.
Thank you. I love it. I would like to thank today's guest, Dr. Fountain. You'll be able to find this episode and information about her on our website at inzuriwellness.com. You can also send us an email or get in touch with us on Instagram at Beauty and the Wise if you want to hear more about this topic or any other topic. Thank you again for joining us.